Good evening, ladies and gentlemen, and welcome to tonight's JCN Facebook Live. We are well aware how busy you are, so a massive thank you from me and the team for joining us. Tonight's unique event is Stop the Pressure 2020 with our awesome friends at TVN2gether. I think that TVN2gether is the most vibrant, the most relevant platform in UK tissue viability at the moment. So it's a real privilege and an honour to have them supporting tonight's event. Alongside me now, we have our speakers. We have Jenny and Alison, who are the two founders of TVN2gether. We have Rachel, Heather, Lisa, Karen, and Siobhan. Good evening, all. Welcome. How are you all? All good? Fantastic. Ladies and gentlemen, as you can see, all our speakers are presenting from home tonight. So if we have any technology issues, please bear with us. I promise you we'll sort it out. The event will be available on our Facebook Live page forever, but we'll also put it up on our jcn.co.uk website where you can watch, but also download the slides. The link for your certificate of attendance will be made available in the comment bar, but also on the main screen towards the end of tonight's event. And that's also relevant for your revalidation portfolio. As all our speakers will agree, the more involved you are tonight, the better it is for them and for the event in general. So leave comments, ask questions, and we'll endeavour to answer as many of them as possible towards the end of tonight's event. Before we start, I want to say a massive thank you to our partners at Medstrom. Medstrom are one of the UK's leading providers of beds and surfaces into the NHS. They're currently providing products and services into over 150 hospitals in the UK and Ireland. They have a long history of partnering TVN2gether. They were involved with the Diane Story video last year that went viral, won loads of awards. So Medstrom, thank you from everyone here and from TVN2gether. Without your passion and your commitment for independent education, these events simply could not and would not take place. So ladies and gentlemen, without further ado, it gives me great pleasure to introduce you to our first speaker tonight, Jenny McDonald, who will introduce the event and also provide a brief overview of TVN2gether. Good evening, Jenny, over to you.
Thanks very much, Ed. My name's Jenny. I'm the lead nurse from NHS Lothian in Edinburgh and also co-founder of TVN2gether. Now, a good place to start is to probably explain what is TVN2gether. We still get asked this question, even though we've been around a few years now. So TVN2gether started off as an idea by myself and Ali, who you can see on the screen at the moment, a few years ago. And essentially the word TVN2gether became a bit of a tagline that signifies TVNs around the UK helping and supporting each other. Now, you might not know that tissue viability is the only speciality that's 100% nurse-led. So when there's issues or concerns or clinical issues on the front line, then that gets escalated to the nurse consultant for tissue viability. That nurse consultant might have a doctorate. On a very rare occasion, that nurse consultant might actually be a professor in tissue viability. But what I'm trying to say is tissue viability is not run by medics, it's run by nurses. And that's why the peer-to-peer support is very, very important to us in our speciality. So TVN2gether started off as a bit of a tagline to signify this support between peers. And then over the last few years, it's grown and it's developed. And TVN2gether is known as a UK network. It's known as an alliance. It's known as a call to action to pull together when it comes to campaigns. TVN2gether have, like I had said, have been heavily involved in leading the national campaign for Stop the Pressure over the last few years. It started off with various iterations of the Red Dot campaign and led on to, like what Ed said, with Diane's story last year, which was really powerful. And this year, TVN2gether decided that obviously with the pandemic and things being difficult in terms of social distancing, we had to think of something to bring education to the masses. Now, usually this time of year, TVNs do stalls, they do educational events, and they do ward walking to raise awareness. And that wasn't possible this year. So TVNs from all across the UK, including Ireland and also the Channel Islands, got together to create a series of videos called 7 Things You Need to Know About Pressure Ulcer Prevention. Now, 6 of those videos are available at the moment on the TVN2gether YouTube channel, so please go and have a look. And the 7th element of that campaign will be covered in this session by Ali later on. So the event today is also reflecting on those videos in terms of best practice and how to implement that at the front line. And at the moment, even more so, implementing best practice for pressure ulcers is very challenging. So we're going to discuss those challenges in a bit more depth. And then what we'll do is we'll go into a live question and answer session. So please do put your questions in the box below and we'll get to them as many as we can. So the first challenge around pressure ulcer prevention is in paediatrics. And for that, I'm going to hand you over to Rachel. Thank you.
Good evening, everyone, and thank you for joining us this evening. Many thanks to those who are organising this event for TVN2gether, and TVN2gether in particular for asking me to be a part of this event today. My name's Rachel. I'm a tissue viability clinical nurse specialist at Great Ormond Street Hospital for Children, and today I'm going to be talking about paediatric pressure ulcers. So pressure ulcer development is often viewed as quite uncommon in paediatric populations, and that's often given the presumed relative ease of being able to reposition and frequently move these patients, because they're often seen as smaller patients, so therefore a lot easier to move. However, we know with survival rates among critically and chronically ill premature neonates and children is increasing, and that's through technological advances. This often increases the risk of pressure ulcer formation for these chronically sick children. We know as well that patients with complex and long-term health needs often require permanent medical devices, and that can be tracheostomies, feeding tubes, non-invasive ventilation, for example, and all those pose a risk to their skin integrity. We also know that young skin, it looks and functions very differently to an adult skin. It's often seen as ideal skin and its characteristics are frequently sought by adults. But the thing we need to remember is that children are not just little adults. Beyond that smooth and supple beauty, there's significant structural and functional differences in their skin. It means that we have to think about handling them differently and trying to help protect their skin, because the self-protection mechanisms that are prevalent in healthy adult skin, they're not developed, and as a result, babies and children, they need that special care to keep their skin healthy. During the first years of life, there's considerable differences and development in the skin and the subcutaneous fat, and that really warrants handling these patients differently and much more cautiously than you would an adult. And even though a baby's skin can feel very chubby and squeezable, we know it's actually a lot thinner than an adult's skin. Overall, a baby's skin is 1/5 of the thickness of an adult's skin. And we also know that premature neonates, they have a higher ratio of that skin surface to their weight, and they often have a decreased or completely absent subcutaneous fat development based on their gestational age. We can see in this diagram the difference between a baby and adult skin. So in an infant's skin, they have the same number of layers as an adult skin, but each layer is considerably thinner and it's made up of much smaller cells. In a newborn, the epidermis doesn't attach as well to the dermis, and that leads to fewer microscopic seals between them, and those are called hemidesmosomes. And this means, unlike in adults, where the skin's tightly sealed together, a baby's epidermis is much easier to get past, and it means they have a higher absorption rate compared with an adult skin. And this higher absorption rate predisposes them to dry, flaky, and impaired skin barrier. And this, coupled with those fewer epidermal cells, it greatly reduces the skin's barrier function. We know that skin resilience builds through infancy. Some of the challenges we have with caring for patients in the paediatric setting when it comes to pressure ulcer prevention is that actually it's a branch of medicine that's caring not only for infants, so small neonates and children, but also adolescents as well. So you've got this vast range of size of patient, from perhaps, you know, a couple of kilograms up to even bariatric patients. And it really poses challenges for clinicians who need to maintain clinical expertise in such a diversity of support surfaces and pressure ulcer prevention products to manage this vast range of patients. Historically, infants and children were placed on support surfaces specifically designed for adults, and we weren't really sure what their clinical efficacy would actually be on patients of smaller stature and lower weight. And because children are not little adults, they need to be placed on a pressure redistribution surface that's actually specifically designed for them and specialist to their loading needs. What we are starting to see is a success in innovation in surface design, and that's starting to see specialist surfaces for neonates and paediatric mattresses with no minimum weight limit being designed. One of the greatest issues we have in pressure ulcers in regards to paediatric patients is medical device related pressure ulcers. They're widely recognised as a massive risk factor for paediatric patients. And this often is due to the fact that medical devices are often designed with adults in mind, and they have to be adapted for paediatric use. And as we've said before, we have this vast size range of patients that we're actually trying to care for. And considering that they do occur under a plethora of medical devices, it's really imperative that we ensure that there's frequent and comprehensive skin inspections underneath those devices, and those devices are either removed or repositioned as frequently as possible. It's really important that we're helping those patients that are unable to communicate their discomfort to us by checking underneath those devices regularly so that we can see those early signs of skin damage. And it's a particular concern with active paediatric patients who are at risk of playing with devices. It can actually lead to clinicians securing those devices to the skin even harder to try and prevent dislodgement. And also that we need to be thinking about how we can use members of the MDT to help us with these devices. So getting in touch with OTs and physios and other specialist nursing teams that have expertise in these devices to see how we can perhaps apply an interface layer to prevent friction and shear, or offload some of it using a gel pad, perhaps, and how that can actually be incorporated into that patient's care when we're unable to remove that device. So our take-home messages tonight around paediatric pressure ulcers are that they do occur in the paediatric population. They can be severe, they can be life-limiting, and they can also cause permanent skin damage to our patients. With that wide variation in patient size, clinicians need to ensure they enhance their knowledge of all these different size surfaces and pressure ulcer prevention products that are available on the market. And we need to be pushing industry to look at the size variation of our patients when they're designing new medical equipment and devices so that they can have specific devices made for them. We also know research is really limited in this field, and more is needed to help support and guide our practice. Thank you very much. I'm now going to pass over to Siobhan, who's going to start talking to us about assessing risk.
Thank you, Rachel, and hello everybody. I'm so glad to be here. I wish we could see you all, but as it is, this is how we're delivering our training this year. So thank you very much to Jenny and Alison for inviting me along to be part of TVN2gether and to cover this section of the acronym of the Asking Bundle, which will be assessing risk and skin inspection. So I'm going to be going over assessing risk. So for any of you that have seen the YouTube videos that led up to these sessions, assessing risk was covered by TVN's Carol and Sarah. And they talked within the YouTube video a lot about the risk assessment tools that we're using, also about the challenges around risk assessment. So it's something which we all do naturally. And as nurses, we do using tools. So a lot of you that are nurses or carers may be using the tools such as Waterloo, Braden or Purpose T, but there are limitations to using these tools. Any of you that have used Waterloo, you can know that it can be very subjective. For example, if you're a diabetic, you've got the option of being a 4, 5 or 6, but what actually makes a 4, 5 and 6? So it can be quite subjective. So although some of us may get fixated a little bit on the numbers that we're looking at, it's more important to make sure that we're evidencing that we're holistically risk assessing. So how do you do that? It's one of those buzzwords is holistic assessment. Well, it means knowing that any of us can be at risk. A lot of you may be carers, or hoping there's a lot of carers here. You might be formal carers, or you might be an informal carer looking for somebody that has an increased risk. But it isn't for necessarily our elderly patients or our elderly residents. It could be, as Rachel said, for very young children. It could be a maternity-related pressure ulcer risk. It could be somebody that is larger and not necessarily bony. And also it could be for people that aren't in bed. We hear the term bed sore quite a lot, and it's one of those terms that doesn't really do us any favours, because we know pressure ulcers can happen not necessarily when you're in bed. So what we find from the research with risk assessment tools is that, yes, we need to use them because our NICE guidelines for pressure ulcer prevention ask us to use them. Actually, that we're already risk assessing. When we walk in and see somebody in a position, in a chair, we may already be thinking about some ways that we need to offload them. So the key messages really that came from the assessing risk is, yes, our NICE guidelines ask us to use one of the tools, but there are variations in them. That anybody can risk assess, and really just looking at your patient holistically as well as using your tool is really, really key, because ceasing acquired pressure ulcers may be just as high as people that are in bed that need assistive turning. So with assessing risk, have a conversation. If you're not sure, if you get a Waterloo 14 and your colleague gets a Waterloo 17 or 18, don't sweat it too much. You're still showing that there is a risk there. If there is a deviation, maybe talk about why. And yes, we need to document our risk assessment scores because our NICE guidelines tell us to, but looking at the whole picture of the patient, the position that they're in, is also part of risk assessment. So if you want to know more about that, Carol and Sarah covered it beautifully. Go on and have a look at the YouTube video and they'll go into a little bit more depth with that. Otherwise, I'm going to move on to the next acronym of the SKIN bundle, or the Asking bundle, which was skin inspection. And this was delivered by myself and Elaine Bethel, looking at tools and what skin inspection means in terms of preventing a pressure ulcer for your resident patient or whoever you're looking after. So the key things with skin inspection is what to look for, is how to pick up early stage pressure damage. Many of you may have heard of the campaign called React to Red, which came out in about 2011, 2012 by TVN Louise McKinley. And it was a really powerful tool at the time because it was about prompting people to pick up on that early stage identification. So we know when you've got a grade 3 or grade 4 pressure ulcer or a suspected deep tissue injury or an unstageable, you're going to have quite a lot of people involved with that person's care. Hopefully you'll have tissue viability in there as well. But actually we know that most of these deep tissue injuries, not all, but a lot of them will start with that early stage pressure damage. So who's going to pick that up first? Will it be the nurses, or will it be the person that has access to that person's skin, be it the patient or resident themselves or the carer? Most of the time now, it will be the carer. And it's really important that we're educating absolutely everybody on how to pick up on early stage pressure damage. The other reason being is that we know now you can reverse that damage. rapidly in some cases if we pick it up early enough. So some category 1 pressure ulcers, which is discoloured skin but intact, where the damage has happened just to the surface of the skin and it's working its way down until it hits a hard surface, which will be bone, a category 4, is that if you pick it up early enough and you take them off that area, then potentially you can get that reperfusion and that area can actually be healed without ever breaking down. So it's really important that we're looking at the skin, but also picking up on that early stage pressure damage. If you don't know about the blanching and non-blanching technique, Google it. There's videos and areas of demonstrating how you can check if you see a red area over a bony prominence, simply giving it a push with your thumb, seeing if it stays red. So really, that's why it's so important about picking up early, so that we can reverse that damage and try and get it healed before it ever breaks down. The other challenge that's come up with skin inspection is identifying between a category 1 pressure ulcer and a suspected deep tissue injury. Both areas are intact, but one, we suspect the damage is done a lot deeper, which is why we suspect it's a deep tissue injury. We can't say for sure, but it is a different sort of colour. It's more like a maroon, and we suspect that that damage is done at a deeper level. So that can be really hard to categorise, guys. So don't worry if you're not sure. Offload straight away, regardless of what you think it is, and then alert. Offload and alert. And then have that conversation with your colleagues and try and get that validated, because it is challenging to try and pick that up. And as TVNs, quite often we'll compare pictures with each other in the teams and say, what do you think? So that's come up as a challenge. And again, we go more into that in the video. The other thing we want to mention about non-blanching erythema or category 1 pressure ulcer is where React to Red is a fantastic tool, because it's about picking up red skin. That's great for Caucasian skin, but for brown or black skin or darker skin tones, it's actually quite difficult to pick up that redness because it's not red. Again, it's more like a maroon colour, but it does depend how dark the skin is. If you want to know a bit more information on that, because there isn't enough pictures, there isn't enough research, this year a medical student called Malak Mkwande published a book with his supervisors, because he's a med student, called Mind the Gap, which was about picking up on skin disorders on brown and black skin. So that's available for you to be able to look at, and I'd strongly advise have a look at that. But otherwise, depending on your demographic, on your area, it's about teaching darker skin. It's not going to be React to Red per se, it will be more like React to purple or maroon, or looking at the other signs of early stage identification. So again, we go more into that into the YouTube video with some other tips and things. Go on and have a look at that. Otherwise, there is so many training tools out there now. You've got the React to Red, you've got the blanching and non-blanching. You've got Elaine, who showed we've got these wonderful apples you can get on Amazon, which actually shows the different depths of pressure injury. When you give them a push, it will actually demonstrate how to blanch. And if you take that away as a carer and you hear room 4's got a red heel and you're on it like a bonnet now and you're checking and you're offloading, you could stop that person getting a category 4 pressure ulcer. We know from the research early identification works, and I'm hoping from today, if you take that away and you hear room 4's got a red heel, you'll be able to offload. So please have a look at more of the information online. There's so many tools for you to use, and especially if you're a carer, you're a champion of the skin, and share it with your colleagues. Otherwise, I'm going to hand over now to Karen Kembry, who's going to cover the surface aspect of the skin bundle. Thank you.
Thank you, Siobhan. That was a fantastic explanation of some of the complex problems we have with skin inspection. My name is Karen Kembry. I'm a Senior Clinical Nurse Specialist for Tissue Viability at Swansea Bay University Health Board. And I'm going to take a few minutes of your time to talk to you about 2 common challenges related to pressure reducing surfaces. So you've assessed your patient's risk, you've checked the skin, and you've selected the pressure reducing surfaces needed for your patient, only to find out there will be a delay in the equipment arriving. So what can you do to minimize the patient's risk while you're waiting? The first thing you need to do is explain to your patient about their risk of pressure ulcers. Ask them to tell you straight away if they feel pain or discomfort, and show them what they can do to relieve pressure. What equipment do you have available? Don't forget about the humble pillow. It's useful for offloading heels in bed and repositioning using the 30-degree tilt. Do you have a mattress overlay available? You can use this while waiting for your powered active mattress to arrive. Have a look around you. Is there equipment being used by other patients that can be stepped down and reused for your patient, adhering to local infection control guidelines, of course? Particularly in the hospital setting, I often see patients with active mattresses who no longer require that level of support. And most importantly, while you're waiting for your equipment to arrive, remember to regularly reposition your patient. If there is a deterioration in the skin, act immediately and increase the frequency of repositioning and skin checks. Another challenge you may come across is when your patient declines to use the equipment you've selected. This is where we need to use our professional skills to encourage collaborative partnerships with patients and their carers. You need to be knowledgeable about pressure ulcer prevention so that you can give your patient enough information in a format that's suitable for them so that they can make an informed choice. To do this, we also have to be knowledgeable about the equipment we would like the patient to use and about what alternatives are available if your first choice is not acceptable. If you feel you don't have enough knowledge or you're not getting anywhere with your patient, don't be afraid to seek advice from a more experienced colleague. Check that your patient understands the risks. Do they know what will happen if they get a pressure ulcer in terms of pain, loss of dignity, and potential for infection? Ask questions to test that the information has been understood. We really do need to try and get to the bottom of why they're declining equipment, and this may take more than one visit or more than one conversation. If we find out what it is they don't like, we may be able to find alternatives that are more acceptable. I had a patient who was dead against an alternating air mattress because he didn't like the feel of the air cells underneath him. But he was happy to accept a hybrid mattress as he couldn't feel the cells underneath the foam layer. So that was a good alternative for him. If your patient continues to decline equipment, it's really important to let them know that they can change their mind at any time and accept equipment. And lastly, don't forget to keep a record of the discussions you have with your patient. Record well. I hope I've given you some practical solutions to two commonly encountered challenges with pressure reducing surfaces. And now I'd like to hand you over to Heather, who will talk to you about the challenges of keeping your patients moving.
Thank you, Karen. I'm Heather Hodgson. I'm the lead nurse for tissue viability in Greater Glasgow and Clyde. I'm delighted to be given this opportunity, and I'm going to be discussing some of the challenges we have in keeping our patients moving. I'm sure every participant here tonight, and I've got all emotional thinking about y'all, we're finding every aspect of caring really challenging just now, and pressure ulcer prevention is just one of these challenges, I know, and tissue viability nurses can be a wee bit blinkered when it comes to preventing pressure damage, but we've got a few ideas to help you tonight, and we're sharing them to help you. And one of the first ones that I have is prioritising, and prioritising has been proven to reduce stress as well as increasing productivity. So I would encourage you all to reflect on what you've done today and try and put it in a priority of order, and really look at things. Could they have been given to somebody else to do, to allow you to do the interventions to keep patients moving? Or did they really need to be done at all? An example that I could give, and I'm sure everybody here has done this, the documentation. Do we really need to be writing up all that we write up? For example, medicines as per Cardex, catheter patent and draining well, vital signs as charted. So that gives you some time that you can reallocate to you putting into repositioning your patients and supporting them in moving. Pressure ulcer interventions can be delegated to other people as well. And have you thought of delegating them to the patients and or carers? Why not engage with patients Simple thing, ask them to look at the clock, and on a certain time, press their buzzer. Nurse comes to reposition. Ask them to stand up, certain time in the clock, go for a walk. Be brave enough to engage them with using their electric profiling bed. What's to stop you or asking a patient or a carer to reprofile, engage the knee? Simple measures like that. Doesn't need to involve nurses, and it gives patients and carers an opportunity to participate and empower them into doing something for themselves. We can also use technology. A simple thing as a timer to remind you or the patient it's time to reposition, it's time to move. We've got a plethora of mattresses and redistributing equipment. And then we can go a stage further using technology by employing, hiring, purchasing equipment that will actually do the repositioning for you. Lots of things that we can do to engage patients, carers in the repositioning and prevent pressure. I'm also going to go on to the next letter, and that is the I, the increased moisture or incontinence. You know, it doesn't need to be urine or feces, it can be perspiration, it can be leaking wounds, etc. And I'm not going to spend a lot of time on this because it's as easy as ABC. There are challenges relating to the continence or increased moisture. There's challenges around protection and early interventions to prevent moisture damage. And there are challenges around the huge number of products that are out there. But if you remember this, ABC, assess your patients. Assess for their continence needs, assess for their toileting needs, assess for products. Do they actually need continence management products, or do they actually need support to get to the toilet? B, barrier products. Early intervention with your barrier products. Far easier to prevent moisture damage than having to treat damage caused by an increase in moisture. And C, continence management. Now that's not providing pad and pants, that's actually stepping back and having a look and thinking, why are we using these pads and pants? Would it not be better to support that person to be mobilising to the toilet or getting them to the toilet? If you're needing to use continence products, make sure they're the right size, make sure they're the right shape, make sure they're the right absorbency. And then hopefully, just following that ABC, we can manage the increase in moisture and prevent patients getting skin damage arising from that. I'd like now to hand over to my colleague in Ireland, Lisa.
Hi, Heather. Thank you very much. Hello all and good evening from Dublin in Ireland. And thanks, Jenny and Ali, for the invite. I'm very sorry, I'm dying of a cold, so I probably sound a bit snotty, but we'll go ahead anyway. So I'm going to talk to you about nutrition and the challenges in practice in relation to nutrition and pressure ulcers. And the first thing that I'll talk about is weight and body mass index and BMI. So we all know that we have to check our patient's weight. And we all know that you know, it's often difficult when a patient comes in and they're unwell and you're asking the patient will offer up a weight to you and say, oh, I'm 10 stone, and it's easy enough to write that down. But often patients haven't weighed themselves recently, and that could be a stone heavier or a stone lighter than they are. So, you know, it's really important to get a baseline weight as soon as possible for an accurate starting point to monitor future weights. And so you can tell that a patient has come into hospital on a certain weight, and if they lose weight or gain weight while in hospital or under your care out in the community, that you have a baseline weight, because the patient might have a difference in their weight. The other thing is BMI. And over here, I have always noticed, and when we look at risk assessment and nutritional screening, like a BMI is needed for nutritional screening and risk assessment tools. And often it's not recorded accurately, and often nurses or staff guess patients' BMI. And guessing someone's BMI can give different scores for everyone, because we all have different ideas what a normal BMI is. So I would encourage people to look at the BMI, get a BMI chart. We all have our phones on us these days. Look up a BMI chart and record your patient's BMI accurately. Then we'll look at referrals to dietitians. An awful lot of patients come into hospital and they don't get referred to a dietitian because maybe the nurse or the healthcare worker feels, oh, well, they're on a balanced diet, they haven't lost any weight, but they have a pressure ulcer or they have a chronic wound. All patients who have a pressure ulcer or chronic wound should be referred to and assessed by a dietitian. Even if they feel that they have the balanced diet and they've no reason to weight loss, supplements can be beneficial for wound healing, such as arginine-enriched drinks and high-protein supplements, or even encouraging your patients to eat different foods to encourage their protein intake and their energy intake. So a referral to a dietitian is very important, and you should note when you're referring to a dietitian that the reason why you're referring to a dietitian is because they have pressure ulcers or because they have a chronic wound. Then you look at equipment. I know in my hospital and in other areas, the availability of equipment for weighing patients is just varies across settings. Some wards might just have a stand-on scales, some might have chair scales, others are lucky enough to have a hoist scales, and if you want to borrow it, you might have to give them a kidney to get it from another ward. Bed scales, some beds have scales, but some areas, especially in the community, they haven't got scales. They might only have a freestanding scales, which they are easily sourced everywhere, but often not suitable for non-mobile patients. And the other area is the bariatric patient. Do we have scales that will weigh a bariatric patient? So will weigh a patient who's over 150 kilos. Some patients that come into hospital, the normal scales that we have at ward level or in the community settings only weigh patients up to 150 kilograms. So do we have the bariatric scales to weigh our patients properly? What happens in the community? Do you have chair scales in the community? Do you have access to hoist scales in the community? If your patient is bedbound out in the community setting, how do you weigh them? Can you weigh them? Then we look at meal times. So meal times in a hospital setting can vary, and there's loads of issues. Florence Nightingale back in the 1800s did say nothing should be done on a ward while patients are having their meals, but often things get done. The drug round happens during meal times. Nurses are taken away to do the drugs. Is there enough patients, enough nurses or staff or healthcare assistants there to help feed your patients? Is there enough? Can you get visitors in? In this time during COVID, we can't have visitors in, so we can't have family members coming in to help feed our patients. We can't have volunteers coming in to help to feed your patients. So is there enough staff out there on the floor to help feed your patients? Like in our hospital, sometimes handover happens at breakfast time. So there's only 3 staff on to help feed a ward full of patients. Should we be looking at staggering meal time? Should we be looking at, giving certain patients who need assistance earlier meal time so we can get assistance for them? We also have the trays. We do have trays. Some patients have different colored trays, and that helps. And then we can look at supplements. So supplements, most of our patients get supplements, whether they're Cubitin drinks or Ensure drinks or different supplements, but they're prescribed by a dietitian or prescribed by a medic. Do nurses know what each supplement contains? So when your patient is refusing to take supplements, because often patients don't really like the supplements. I've tried supplements and some of them really do taste horrendous. Like, do the nurses and the healthcare assistants have enough education around supplements and what they can do for a patient and how they can help a patient to encourage this patient eating them? Are the supplements left on a bedside to go warm? Can they be left in a fridge? Can they be given at different times? Can we ask the patients what flavours they prefer? Do we have the full range of flavours available at ward level? Should nurses get more education? So should some carers and healthcare workers get more education around supplements? And finally, talk to your patients, ask the right questions when you're talking about nutrition with your patients. Ask them what they eat, what they like to eat. What is their meal times balanced? Do they eat a healthy, balanced diet at home? Do they just have sandwiches? Do they have protein? Ask them questions about what they eat, what their diet is like at home, what they like to eat. See if you can get food that they like to eat while they're in hospital, or make it available to them. Ask them questions about their weight. Have they lost weight? Are their clothes too big? Have their clothes gotten bigger? Do they have to have an extra hole in their belt compared to normal? Ask them the questions around nutrition to encourage them to tell you what they're eating. And that's it. And finally, I'm going to hand over to Alison Schofield, who's going to talk to you about giving information. Thank you.
Hello, everybody. We always said there was going to be one of us who kept ourselves on mute, and it always is me. So thank you, everybody. Here we are. And oh, do you know what? How amazing is this? We've jumped from all corners of the UK and Ireland, and then here we are, and I'm here live in my house in Yorkshire. And this is just an amazing evening for us all from TVN2gether, and thank you to JCN and Medstron for supporting us. So I am the seventh element of all the aspects of care that we have delivered to you tonight and through the YouTube channel, which you can access, and they will be there, as Jenny said, forever for you to look at and use as educational sources. So the seventh aspect of care is the G, which is for the giving of information advice. And this is so important because it wraps up all those important aspects of care. So we have objectives within the information giving that we are providing to our patients, their families and their carers. So we must understand the importance of the patient-centeredness at the heart of everything that we deliver and we do. And also, you know, we've had this year, haven't we, this strange year, and we're in this second wave of the COVID-19 pandemic. And there's been a lot of talk around self-care. I personally like to talk about it as shared care. And even in pressure ulcer prevention and management aspects that, you know, we must address this as well. So we must form you know, care plans with the patient at the heart of all our decision making, and be giving them, you know, absolute reliable information so that they can carry out and share their interventions and care with us to prevent and manage pressure ulcers. So we want to ensure that the patient and carers are able to raise their concerns when they need to. So that's, you know, about giving information around red flags. So, you know, we've heard about skin inspection and signs and symptoms of you know, issues when they're raised on the skin. And we can teach, you know, family, patients and carers to be able to do this. You know, and then we're giving them the contact numbers to call if they have an issue. I work in a community setting, so I'm kind of relating it to that, where patients are often, you know, in their homes, you know, and without carer contact, you know, 24 hours a day, but also within our care homes as well. So we're you know, we're empowering our carers in our care homes to be able to identify any issues that are there. We want to be promoting this as a health education issue. You know, chronic wounds is a chronic disease, and we need to eradicate it as much as possible. So it is an important health education message. We want to ensure that your teams have, or you need to ensure that your teams have the right information. So it's not just a case of, you know, we go out, we do our visits or on the ward, and we're just, you know, we're giving just some, you know, verbal type of information. You know, have we got the right information? What is it that we need to give to enforce these messages? And we need to raise awareness of our local guidelines and also the national guidelines. So that might include NICE guidance, messages from and guidance from NHSI, National Institute for Clinical, Effectiveness, everything like that. But also we all have our local messages too. So ultimately we want to demonstrate that we're doing everything in a safe and caring way, that it's effective, and that we are, we're driving the leadership with this. So we're getting, that good response back. So, the element of information is extremely important. So we need to assess with our patients, and everything is always on an individual basis, what is the best form of information given? So, how do we communicate that with our patients? We have, is it literature? Is it videos? And there's lots of information available now, and there will be much more so because of the way we are communicating, and we have lots of virtual education. We have to consider as well, any language barriers. We have to consider aiming at the right educational level, at people's ages, and how do we provide that? And also, is there a capacity issue? Is there, and how do we change that and get that information across to patients and their carers? We need to identify the patients who are at the risk, to whom that information should be given. So what information do we need to provide? So we mentioned about different types. There's written, verbal, electronic. So let's not forget that our patients are often really want this information. We can't assume that they're not going to understand how a pressure ulcer occurs or what to do to prevent that. We give them the advice on a level of that they are going to understand it. But, we have to change those traditional roles that we've always had within nursing of, we will provide the intervention, we will, do to the patient, because the patient needs to be, at the centre and remember that shared care management. So we need to give them the full information that is there. We need to show them how to check the skin and what signs to look out for. We need to advise them on the equipment. Remember, equipment that we give is part of a prescription. So we need to show them how to use it and tell them if there's any issues and problems, who to contact. And demonstration, don't forget the demonstration. In my team, we have a team of pressure ulcer prevention associate nurses, and they go into care homes and they show carers how to do repositioning, how to do 30-degree tilts, and that absolutely is invaluable. And there's and don't forget about continence care tips, all these aspects of care that have been talked about tonight. There is advice available on all of these. So nutrition and hydration, understanding when to raise the concerns, and that shared care. So these are just some of the things I picked out from some of the information that we provide to our carers and patients. There's so many things out there, look on all the websites, around nutrition, around, how to check skin, exercise, 30-degree tilts and things like that. So, there's lots and lots of resources to use. So, don't underestimate any of that. So thank you so much. I'm going to now hand back to Ed, and we'll move on to our live question and answer sessions. Thank you everybody so much for listening.
Ali, thank you. That was brilliant, and thank you everyone. Just outstanding session, and thank you to everyone watching and listening from home for all your comments and questions. So based on the number of questions, guys, you mind if I crack on with question number one? What I'll do is I have a list here of who should answer the question. If you guys want to chip in, raise your hand, no problem at all. So the first question is for you, Shiv. How can we check for a grade 1 pressure ulcer on brown or black skin? And are there any tools that can help?
Oh, thanks, Ed. And yeah, that's a really, really good question. I think it's very pertinent this year on the back of campaigns like Black Lives Matter, where we're looking medically and nurse-led around how we're checking the skin, and especially as skin specialists, you know, where we diagnose from what we're looking at a lot of the time on the skin. We look at skin changes, like discussing what those changes look like on darker skin tones is really, really pertinent. So there is no, there's not great pictures, to be quite honest, on brown and black skin of non-blanching erythema or category 1. But have a look at the YouTube video. The other signs and symptoms would be, it can be hard because of the inflammation response. It can be quite hard to touch. It may be increased heat, again, because of the inflammation response. But if they're sitting on their bum, they might have a hot bum. So take them off it first, and then wait 10 minutes and then have a little feel next to the skin, and then where you think the pressure damage might be, and see if there's a heat difference. They may complain of pain because of the impact on the nerve endings. So they may say my bum sore or my foot sore or whatever. So looking at the other signs and symptoms, and I go to that more in depth on the YouTube video if you want to go back on and refer to that. I'll just lastly say, do check out Malek Makonde's Mind the Gap book, which has come out this year, which is on lots of different skin conditions on brown and black skin.
Brilliant, thank you, Shiv. So question 2 from Jane. So Rachel, we're going to give you a go. If you sound like a Dalek, I'll hand you back over to Shiv. Should pressure ulcers to lips or the anus from medical devices be categorized the same way as other pressure ulcers?
Can everybody hear me? Quick check. Yay! So mucosal membrane pressure ulcers, we don't actually categorize. There's a great poster that came out from NHS England, I think last year, for Stop the Pressure Day, and it actually clearly states about device-related pressure ulcers, and it also talks about those to mucosal membranes and how they're not categorized. So hopefully that answers that question for you.
Brilliant, thank you. So question from Natasha. Jenny, this is for you. Would it be fair to say that all pressure ulcers are preventable in the current climate of COVID, i.e. poor cell perfusion?
Yeah, it's always a question that comes up, Ed. Thanks, Natasha, for that. Now, many years ago, we used to say that 95% of pressure ulcers were preventable. We since have known that isn't the case. And COVID very much gives us a different spin on pressure ulcer prevention. In terms of COVID, obviously, it affects the respiratory system. So in terms of the skin becomes hypoxic, which means low oxygen. So COVID does have detrimental effects on the skin, not just in pressure ulcer prevention, but lots of other skin concerns. So that's the first thing to think about. In terms of COVID, the other thing we should be thinking about is actually one of the treatments for COVID patients is to prone them. So you prone a patient, which means that you assist them to lie on their front, because that helps with their chest expansion. But with that, it helps their respiratory system. But what it does do is create an abnormal pressure on the front of the person's body. And that has been known to increase pressure ulcers recently during the COVID pandemic. Areas on your body, for example, your bones here, your jaw, your cheekbone, your zygomatic area are now seeing an increase in pressure ulcers because of that abnormal repositioning of COVID patients, obviously to help with their respiratory system. The other thing related to COVID is we're seeing an increase in pressure ulcers caused by medical devices. With ITUs being higher, being fuller essentially over the pandemic, we're seeing a higher use of medical devices. And we know medical devices cause pressure ulcers. We have to check under medical devices as frequently as we're checking other areas in the skin, whether that's an NG tube on the nostril, whether that's a tracheostomy or a tube, an ET tube in the mouth to help with breathing. All these medical devices are at risk of causing pressure ulcers. So that's probably the 3 things that have changed in terms of pressure ulcer prevention in the COVID pandemic.
Jenny, thank you. So question number 4, Shiv, this is for you, from Kunju. Would you please explain about moisture lesions also? What are the key differences from pressure ulcers?
So a question that comes up all the time, and it's not a pressure ulcer, essentially, but it can go together. A moisture lesion is effectively our pH balance in our skin is around 5.5. It's slightly acidic. Excess urine, feces, sweat can make it a little bit more alkaline, which kind of breaks down the structures of the skin, the top level, which are like building bricks. So basically, when your pH balance is wrong, it can go through the building bricks, break it down, and it can be slightly superficial, a bit down to the deep dermal part of the skin, which looks like a category 2 pressure ulcer. So it's really common that they are misdiagnosed, but one is from excess moisture and the other one is from pressure, but they can go together, and we call those mixed lesions. But the pathways of care are different. One is offloading the pressure, the other one is about maintaining that pH balance of the skin, and that's about cleansing it properly, but also putting your barrier creams or sprays or whatever barrier, topical barrier you're putting on to protect those building structures of the skin. I hope that makes sense.
Yeah, perfect, Shiv. Thank you. Question 5, Heather, this is for you. From Craig. Thank you, Craig. What is the best way to apply barrier products within a care setting? I usually apply to skin, but I've seen a few practitioners rubbing it into the continence pad, saying it lasts longer.
Craig, I've never heard of that. These products are for direct application to the skin, following manufacturer's instructions, and they have not to be buttered on. You shouldn't really see the product once it's been applied, and you only need to apply it as often as really the manufacturer's instructions, because they are designed to be taken up by the skin and they sit there to protect the skin. So never heard of that one, putting it on. And actually, by putting it directly onto these continence management products, you actually interfere with the way they work. And that's something you also need to take into consideration, is what barrier product you're using. They've got to be compatible with the continence products you're using, because sometimes they can block the pores.
Thank you, Heather. Shiv, do you want to add something?
Just very briefly on the back of that, because I know it's something we all see. I'm not going to mention the product, but just be warned of the zinc-based oxide creams, the ones that look white, that when I was a carer 20 years ago, I used to slather on the buttocks. And if there was 2 white shiny buttocks, I think I was doing a good job. So that still happens. So just be warned, the zinc oxide ones, because you have to rub the skin a lot, but it also blocks the continence pad from absorbing the urine. So I don't want to mention any brands, but just watch out for that. Don't worry if you still see it, but challenge it.
Thanks, Shiv. So question 6 from Faye. So this is for Lisa. It's very difficult for diet promotion with dementia patients who decline food. Do you have any ideas?
Well, it's all about talking to the patient and reassuring the patient. And, you know, most patients who have dementia, there probably is some sort of way that you can talk to them and reassure them and relax them into eating what you want them to eat, and find out of family members and find out of relatives or carers what they prefer to eat. Is there any preference in what they prefer to eat? You know, I know we've had patients in over the years who have dementia, and they won't eat the food in the hospital because they're not used to it and they're set in their ways. So maybe sometimes you have to go outside of the rules and bring food into the patients, food in that you know they'll eat. If they'll only eat their wife's food or their husband's food or their daughter's food, they'll have to bring it in and just encourage it that way. But I think an awful lot of the time it's about reassuring the patient and, you know, talking to them kindly and gently, and, you know, going to their level to talk to them and to encourage them to eat what you're trying to give them, but to involve family members, really.
Brilliant, thank you. Thank you. So incredibly, I'm looking at the clock, our hour is almost up. So we come to our final question, which is for you, Jenny. So this is from Chantel. Thank you, Chantel. Could you talk a little bit about how pressure ulcer prevention might be different with patients in end-of-life care?
Yeah, thanks, Ed. It is very different in end-of-life care. When we become end-of-life, there is a term known as skin failure. Just like at the end of life, we might have respiratory failure or liver failure or heart failure, the skin fails too. And in terms of pressure ulcer prevention, they used to be called Kennedy ulcers at end of life. We don't call them that anymore, but we do know that they are slightly different to what we would call a normal pressure ulcers. Pressure ulcers at end of life tend to happen very rapidly. And there's also a key physical characteristic of end-of-life pressure ulcers. They've got quite a distinct shape. So pressure ulcers at end of life can be horseshoe shaped or shaped like a pear. And that's why we know it's skin failure at end of life. There's no consensus nationally or internationally how quickly they happen towards end of life. Some literature will tell us a pressure ulcer end of life will happen within 48 hours of before the patient dies, and some literature says within 2 weeks. So it does vary significantly. They're not always preventable. We have to remind ourselves of that. It is skin failure at the end of the day, but what we need to do is to optimize that person's care as much as we possibly can. Now, at end of life, repositioning is slightly different and our approach is slightly different because we are prioritizing comfort and pain and dignity at end of life. But what I always teach in terms of end of life pressure ulcers is optimize the patient's care as much as the patient will allow, and that's in terms of repositioning. I hope that answers the questions, how they're slightly different.
Listen, thank you. And just thank you all for an amazing event. Guys, I know we were all a bit nervous before this one, but it was just outstanding. And thank you, ladies and gentlemen, for your amazing, kind words and comments. Speakers, if you get a chance to look back at this session on Facebook, do, because there's some lovely comments in the comment box. The certificate for attendance is now available for download. So that'll be on the screen, that'll be in the comment bar, so please click there. There's more education on the jcn.co.uk page, so also go there. So that concludes tonight's event. Thank you so much, speakers. You were genuinely awesome. Thank you, TVN Together. It's been an outstanding hour. A big thank you to Medstrom again for your patience over the last month, for your passion, for your involvement. As always, a thank you to Mole Digital and the JCN team. So much work goes in behind the scenes that you guys aren't aware of. So a big thank you from me to you all. And finally, last but not least, to you incredible healthcare professionals out there. You continue to inspire me, my team, and the nation. Stay safe, stay strong. Have a lovely evening. We'll see you all very soon. Good night.
Bye, everybody. Thank you.
Bye.
Bye.